Peritoneal metastases or PM develop in up to 60% of patients with midgut neuroendocrine neoplasms or NENs. In our guideline, developed by Delphi Consensus Methodology, we describe several key principles of both the surgical and systemic management of NE and PM. Curative intent surgery should be considered where feasible, but when not feasible due to disease burden or patient factors, palliative intent surgery may still be considered, as it is often the only effective modality for palliation of symptoms such as bowel obstruction and discomfort from mass effect. We also touch on the early identification of carcinoid syndrome and the use of octreotide. Lastly, we comment on cabozantinib as an emerging treatment for advanced NETs based on the recent CABINET trial, which demonstrated improved PFS compared to placebo. The treatment pathway is stratified by tumor grade and differentiation based on WHO classification. In well differentiated neuroendocrine tumors, cytoreductive surgery is often the first consideration, particularly when complete or near complete cytoreduction is achievable and functional symptoms have been addressed. In contrast, individuals with grade 3 well differentiated NETs may first be considered for systemic therapy, followed by reevaluation for surgical intervention if there's a clinically significant response. We also highlight the importance of individualized surveillance intervals based on estimated risk of disease progression. One of the most notable changes is how the current pathway differentiates management based on the WHO classification of grading and tumor burden, steering away from the prior algorithms based on liver involvement. Surgery can be considered in patients with disease amenable to complete or near complete cytoreduction and those with well differentiated NENs. We additionally provide guidance for managing recurrent or initially unresectable disease.